A very good evening to all. I welcome respected President MahaIP, Dr. Ramakant Patil sir, and Honorable Secretary General Dr. Amol Pawar sir. I welcome all delegate, esteemed speakers, OBs and executive members, CIP as well as MahaIP. A warm welcome to all. This session is brought to you by Maharashtra IP as well as Women's Committee MahaIP. This session had been awarded 2 credit points. Myself, Dr. Sonali Shirbhate, Chairperson, Women's Committee, MahaIP, and my co-host, Dr. Mangai Sinha, Zonal EB, Women's Committee. She is Secretary, IIP Navi Mumbai. Over to you, Dr. Mangai.
Thank you, ma'am. I take this opportunity to welcome all the esteemed delegates and all the esteemed guests who have joined us here today for the Tuesday Takes. Tuesday Takes is an excellent, fun, thrilling way of delivering academics, varied topics in a short span. It's an extremely unique concept, conceptualized and executed successfully last year, bringing speakers from all zones of Maharashtra together on a common platform. The cherry on the cake is the experts' opinion, which comes in the end, and their views, which completes the topic in total. The module is the Tuesday Takes follows the rule that there are speakers. So this year we have the fantastic 5. So 5 speakers from different zones of Maharashtra who have been allotted a topic and 8 minutes for each topic. Followed by their topic, there will be the experts who will give their views, which for the experts' view, we have 2 to 3 minutes allotted to them. This is how we are going to follow. So here we are with the second year or season 2 of the Tuesday Takes, like they call it nowadays. So the Women's Committee is extremely happy to have run this successfully last year. And we are really thankful to the Maharashtra IIP for allowing us and giving us this opportunity to conduct the Tuesday Takes. So Maharashtra Academy of Pediatrics, Maha-IIP, and Women's Committee, Maha-IIP, proudly present the Tuesday Takes. Before we go on with the academics, let me take this opportunity to welcome Maharashtra State IIP President, Dr. Ramakant Patil sir, and request sir to please declare the Maha-IIP Women's Team for this year and give his valuable views. So, welcome, sir.
Sir, kindly unmute yourself. Kindly unmute.
Thank you, Pallavi ma'am. It gives me an immense pleasure to set this ball rolling of Tuesday Takes and all the varied programs which were very successful last year. And this time we are going to introduce few more topics and a few more different programs. And it's like really a space drop of this thing, a ride, which is very wonderful. But here this ride is academic. And at the outset, I welcome this fantastic women committee under the leadership of Dr. Sonali Shirbhate, who is ably assisted by Dr. Neha Singh. And we have got a very good representation from across Maharashtra. We have got Dr. Mangai Sinha from Navi Mumbai, Dr. Manjusha Sherkar from Aurangabad, Dr. Shilpa Dudgaonkar from Pune, Dr. Nivedita, Dr. Dipti Deshmukh, Dr. Pallavi Patil from Chalisgaon, Jalgaon, Suchita Madam, then Dr. Grivita Raikar from Thane, very active member Dr. Swati Patil from Yavatmal, and Dr. Sonal Shinde. So this expert group, please forgive me if I have forgot any name. It is not intentional, but please blame it on my gray hairs. So if I have forgot some names, and this team will be ably guided by, supported by ex-officer of CIIP, Dr. Renu Poralkar, who is a CIIP executive board member from Maharashtra, and being this CIP member, she will be ex officio for this women's committee. Let us call this as women's committee and not a women's wing. And I congratulate Sonali and Neha for doing wonderful work at backstage and making this first program of Tuesday Takes to the fore and in reality. At the same time, I will welcome and thank Dr. Manish Jain, who is very good friend of mine and who has been a head of department at Varda and who has consented to be expert today. Similarly, I welcome and thank my very good friend, Dr. Sanjay Gosavi, who is observer from MMC. And very good speakers, galaxy of speakers, 5 speakers have been chosen today for this Tuesday Takes. And they have taken very good topics also, like Dr. Ripa Ghosh, Amol Murkote, Dr. Rahul Patil, Anil Syed, and Dr. Nachiket Inamdar. And they have taken a very run of the mill, but very important topics for Tuesday Takes. And this concept will definitely have made a lot of impact last year. And to have the simplicity and same thing, what is Tuesday Take? People already know about Tuesday Take. So same day it was available on Tuesdays. And the name we have kept, we don't want to have Navi Viti, Navi Rajya. But same thing we want to continue, have a legacy of wonderful programs. And so many, it is very nice and heartening to see that already 100 participants are there on this platform. So it speaks its volume about the publicity or about the interest and curiosity of people across Maharashtra to listen to this galaxy of speakers. I thank all this women committee and I express gratitude from Maha-AP office, from all the Maha-AP EBs that they have taken this responsibility and they will definitely work and for different programs which we want to do programs at least at a single go with public-private partnership from government and at least once in a 3 months on a single day all Maha-AP branches will be doing the same program. And further programs are there in pipeline. Those will be unveiled and I am very sure that this women's committee team along with our able executive board member of Maha-AP will bring it to the reality and it will be a big bang success. Thank you, friends. Thank you for giving me an opportunity and I really welcome you all. I welcome all the speakers. Thank you.
Thank
Over
you,
to
sir.
you.
Thank you. Thank you for your encouraging words and thank you for taking your precious time out to be with us. On behalf of Women's Committee, I can assure you that we will do our best so that every program that we do and conduct is always a success. Thank you so much, sir. I now take this opportunity to welcome Secretary General Maharashtra IAP, Dr. Amol Pawar. Sir, please, and I request sir to say a few words.
Thank you. Thank you, Mangai madam. After Pedicon, we are all back with the academics of Maha-AP and tomorrow is 1st March and this was the last day of February and 15-20 days back also we conducted a meeting with Women Committee and we finalized this thing. So good evening all Maha-APians present for this very innovative Maha-AP academic activity that is Tuesday Takes. This activity was started and carried out whole last year by Maha-AP with the help of Maha-AP Women Committee headed by Dr. Renu Boralkar ma'am and Dr. Sonali Shirbate ma'am. And it involved all the 43 branches across the state. Mainly young speakers were involved in it and who gave very important take-home messages to us all on various important topics which we face in day-to-day practice. This year also we are back with the same Tuesday Takes to encourage our young speakers, young Maha-APians for their presentations. I appeal all Maha-APians to attend all the academic activities which will be carried out from this month onward. And I welcome Dr. Sanjay Gosavi sir also, who is MMC observer. His appeal is that those who are attending the complete session, they only will get the 2 MMC points. So I request all to attend the session completely And those who cannot attend this session on Zoom, please write your IAP number and MMC registration number in chat box of YouTube also. Thank you, Mangai ma'am. Over to you.
Thank you, sir. Thank you for your valuable words. We are also privileged today to have with us Dr. Renu Boralkar. She is EB member, Central IAP, and last year she was, and last year, even this year, she's very much a part of us. And this entire concept has been the major way of conceptualizing this Tuesday Takes. It is her and her idea. So may I please request ma'am to say a few words.
Good evening, all. Thank you, dear Mangai ma'am, to have kind words. And I take this opportunity to congratulate Dr. R.D. Patil, President MAIP 2023, and Dr. Amol Pawar for this excellent bang on Tuesday Tech startup today. And also I congratulate Dr. Sonali Shirbhate, the chairperson of the Women's Committee, along with Dr. Neha Singh and all the team members for the zonal coordinators. And I wish all of them a best luck. Like last year, me, myself, and Sonali, and all the zonal coordinator members with the President Dr. Gangolia and Secretary Amol Pawar, they had the initiative. But to tell you the truth, it was from N.K. Subramaniam that we got the this inspiration. He had taken this thing in a few conferences, and so we put forth our this workup in front of Gangolia sir, and he gave us a free hand. And me and Sonali, along with my all the team and support from the President and Secretary at that time, could conduct the program successfully with giving 66 speakers, new speakers, the dais from all the corners of Maharashtra and all the zones represented. And Dr. Amol gave an excellent idea to have an MMC points for this, which made this program the hit success. And I thank Amol Pawar from the bottom of the heart. So thank you once again, and best luck to all of the next series, to all of you. Thank you so much for giving me the time and opportunity.
Thank you so much, Dr. Renu ma'am. I now welcome and I now want to introduce the women behind today's Tuesday Talks in such a short span. Like we were all busy with the Pedicon and then we wanted to start today's program, but in a very short span, even I must say the speakers also got less time this month, but they were all ready with the talks. So the women behind today's talk, the backbone of today's talk, who managed everything in such a short span. The chairperson, Women's Committee, Dr. Sonali Shirbhate ma'am. I welcome ma'am and I request her to please start the Tuesday Takes today.
Thank you, Dr. Mangai, for your so kind words. Thank you very much. I'm really very thankful to Dr. Ramakant Patil sir, President MAIP, as well as Dr. Amol Pawar sir, Secretary General of MAIP, for huge efforts to select these all EBs, zonal EBs for this team. And I'm very happiest with Dr. Neha Singh as co-chairperson and Dr. Manju Sherkar as convener, as well as we will be having our all zonal members this year with great enthusiasm. I welcome all the zonal members and I'm really happy for them. They are all here with a great enthusiasm. Thank you, Renu ma'am, for your kind words. So not wasting much time. So let's start our session. I would like to introduce first our esteemed judge for this session, Dr. Manish Jain sir. He is from Sevagram, Wardha.
Sonali ma'am. Sonali ma'am.
Yes.
Before that, please acknowledge the presence
yes,
of Dr.
Sir, I'm yes. Sir, after this, can I?
सुरुवातीलाच करून दिलं तर चांगलं.
बरोबर.
Ready.
I acknowledge the presence of Dr. Sanjay Gosavi sir. He is senior pediatrician from Nashik and he is MMC observer. Sir, I would request you to have just few words for us, Dr. Sanjay Gosavi sir.
Good evening, everybody. Am I audible? Hello?
Yes,
Yes,
sir.
sir.
Yes.
Yeah.
Loud and clear.
Yeah. Good evening, everybody. Ramakant, is that okay?
Yes.
Yes.
Yeah.
Always okay.
Yeah. Yeah. Welcome all delegates. This Tuesday Takes is a very innovative idea, especially by the Women Committee members. Without wasting much time, I'll request you all to start the lectures and see that you attend the full course. Thank you. Thank you.
Thank you very much, sir. I would like to introduce our esteemed expert, our esteemed judge for this session, Dr. Manish Jain, sir. He is from Sevagram, Varda. He is MBBS, MD, PG diploma in adolescents. He is approved UG and PG teachers by MUHS. He has a 19-year of experience of teaching. He is national faculty for many of the IAP modules like NSSK, NALS, PALS, NRP, BLS, vaccinology, and so many. He had up till now 29 publications and 18 conference abstract. His 2 books are published on medico-legal ethics. So I welcome Dr. Manish Jain, sir. Sir, I would request you to have a few words for our all esteemed speakers to encourage them.
Thank you, Sonali madam. At the outset, I would like to thank Maharashtra IAP, especially Honorable President Maharashtra IAP, Dr. Patil sir, Dr. Amol Pawar sir, and a special thanks to Women's Committee of Maha IAP, Dr. Sonali madam, to you and other office bearers of your Women's Committee for considering my name as expert for this precious program. And I wish all the best to all the speakers. Thank you.
Thank you very much, sir. So let's start our session today. As it is our first session, so we had been so much of initial all the thankfulness, but from next we will be starting it directly. So I invite our first speaker, Dr. Ripa Agrawal Ghosh from Mumbai Konkan Zone. She is EB of Mumbai IIP and she is a member of IIP NRC, European Society of Infectious Diseases. So welcome Dr. Ripa Agrawal ma'am. And her topic is pyrexia of unknown origin. Dr. Ripa, can you directly share the slides and unmute yourself?
Thank you, Madam Sonali, Madam, and thank you everybody from Maharashtra IAP as well as the Maharashtra IAP Women's Committee for giving me this opportunity to speak on this challenging topic, pyrexia of unknown origin. And I hope this is not counted in those 8 minutes because I'll have to otherwise go in a lightning speed because the time duration is just 8 minutes. And I also thank Dr. Manish Jain sir for being the expert of this session, and I look forward to learn from sir and from all the other speakers today. So now this pyrexia of unknown origin, which is also we can think of it like a UFO because I try to think it like a FUO. Madam, my slides, I think I'm unable to move them. So if Pallavi madam can help me with that because this is stuck from my side. But in the meanwhile, I'll continue with the talk. So in this pyrexia of unknown origin, I'll be just talking about the approach to PUO, which will help all of us in our day-to-day practice. Now, the definition. So now this definition has kept on changing. And
Madam, can you please double click your slide?
Yes, perfect. Thank you so much. Yeah, okay. So as I was telling that the definition has changed now, like what we used to study, that was a 1961 Petersdorf definition of 3 weeks of fever, 1 week of hospitalization, all that is gone now. So currently it is a febrile illness after 8 or more days. And most important here, I would like to point out is that sometimes, nowadays parents are, because of COVID era, they have these gun thermometers or the infrared thermometers. So basically here, the temperature which we are talking about is the core temperature, right? So that is important. Second, the degree of fever. So the degree of fever which we consider as for FUO is 38.3 Celsius or 100.4 or more than that. Right, so that is important. And if this of course, most of us will work up the patients even before 8 days, right? So we are doing the screening lab test, and still if we don't find any focus or we are unable to understand the cause, then we are dealing with a FUO. So for the classification, now this is mainly for adults, but the classification is classic, and I'll be talking only about the classic FUO. Nosocomial is when a patient gets fever while admitted in the hospital. Neutropenic when the neutrophil count is less than 500, and then HIV associated. But let's only talk about today the classic PUO and what are the etiologies, one must think when we come across such a patient. So if you will have a look on the right side, we can see these bars, and the largest bar which we are seeing is of infections. So this I have taken from a study, a wonderful study, which was conducted in Hyderabad by Reddy and Associates. In this, they try to understand the etiology from Indian point of view, and they found that the most common etiology is infection. So we have to first rule out infection, that is at most important. Now the second, the green one here, is malignancy or neoplasms, that is around 20% of it, and the others could be due to connective tissue diseases, miscellaneous other inflammatory conditions. But let me be very honest here, like many times we do not have a diagnosis and these patients remain undiagnosed. But what we have also seen is that some patients have a self-limiting illness, and it is a benign self-limiting illness, but unfortunately till now there are certain conditions where we are unable to know the cause. Now mostly it's if when a patient has fever for a very long time, you may see this patient, either you're seeing this patient on day 10 of fever, or maybe you're seeing this patient on day 20 of fever, okay, depending on when this patient comes across. So what is most important here is to understand is that please do not just look at the records or the file first. It's always important to start afresh, right? So it's important for us to re-go and to again start talking to the patient, again look at the history properly, do a thorough clinical examination once again, look at the investigations, and then if required, then investigate further. Depending on that, the management will be. So main thing is you have to stop, you have to look, and then you have to go ahead. Now in history, we know any disease in the human body is an interaction between the host, the agent, and the environment, right? So the history also, when you are taking the history, try to understand these three aspects of the patient. And for the fever, it's very important to know the pattern of the fever. And sometimes, we all know that fever is one of the causes the mother or the parents come to us. Try to understand how they are taking this temperature, where are they measuring, whether it is really documented or not. Those things are extremely important. And also try to understand that whether this is really a prolonged fever or is it a recurrent fever, right? Because that will help us in understanding the etiology. I have put down points here, right? Because of the lack of time, I will not go in details. Important to understand the travel history, the immunization history of any unpasteurized milk consumption, any recurrent illnesses, and of course the drug history. Now this clinical examination, as I mentioned, we are going to do it as if this patient we're starting afresh. So suppose you had already seen this patient like 4 days before or a week before. Now redo the clinical examination, try to actively look for clues. We know that in systemic onset JIA, the patient will have an evanescent rash whenever there is a spike of fever. Try to look for it. Try to ask the parents to take a picture if they see some rashes which are transient, okay, because otherwise we may miss them. Now, of course, if it's a sick-looking child or toxic child, then your management will completely change. So that we have to understand. If you're dealing with sepsis, then we will feel it like a septic child. Now, coming back to only a prolonged fever, a PUO where the child is vitally stable, you take that opportunity to examine closely, look at the eyes. Now, eyes is so important. It can, even the fundus, if there are choroid tubercles there, you never know, because all this is going to help in decreasing our differential diagnosis. Now, this sinus tenderness. Now, I really want to point this out because this has also been given by the study was done by Dr. Tanu Singhal madam, in which she has pointed very clearly that one of the causes of PUO has been sinusitis, okay, and which was picked up on CT scans. So something like a sinusitis also is a cause of PUO, because sometimes this can be partially treated. So sinuses and tonsils, your thyroid, because thyroiditis also is a cause of PUO, even hyperthyroidism. Heart murmurs for your infective endocarditis. Of course, we all look for the organomegaly, but it's important to look at the musculoskeletal system. The PGALs, hardly how much time it takes to do a PGAL. Do that PGAL, it will really help us. Look for lymph nodes, look for pallor, and of course, as I mentioned, the skin. Skin is extremely important. Now, I really want to focus on this, that stop, look and go, because now once you have done the history, you have done the clinical examination, now there is something, you're formulating a differential in your mind. Depending on that only, we are going to order our tests. Also, we are going to look at the previous tests. Now, this is quite a busy slide. Why? Because now we are in 2023, we have such magnificent tests available. There are, panels available. You can just order panels, but is it really helpful? No, it's not helpful. It has to be a targeted approach. It has to be depending upon your local epidemiology. If the patient is from an area where rickettsial infections are common, of course you'll check for rickettsia, but it would not help to check for rickettsia in a patient where you feel that there has been no exposure to ticks. So I think those things are quite important, because otherwise, we have everything under the roof today. But mind you, even with these tests, there are times where the etiology is not able to be picked up and it remains undiagnosed, right? So this is quite important, that everything has to be targeted. Okay, now there is a situation where you're not able to understand anything. This PO is not having, or you are not getting even any clinical clues. Then what? So in such situations, you will go stepwise. There is importance of doing the autoantibodies, looking for the rheumatic kind of illnesses, and even going for a blood back tech and even extended blood cultures. So if the child is already on antibiotics, of course the yield of the cultures are going to be less, right? So apart from that, keeping that in mind, it's a blood back tech can be done. Extended blood cultures here I've mentioned because something like a brucellosis will take a longer time to grow. So it may not be picked up in like 48 hours. Urine cultures are important. Even bone marrow cultures, for that sake, can help us. And TB, if you are in India, one just cannot, there has to be the highest suspicion for TB in anyone, in our cases of FUO, because it could be an atypical presentation of TB. So here again, I'm emphasizing it is repetitive, because I really want in this session to make you agree with me that we are going to redo, recheck, and then only we are going to retest. Now for the imaging. So imaging also is whether if chest X has already been done and you are not finding anything more on your.
Madam, we are more time, so kindly wind up.
Yeah, this is my almost last slide. Thank you, madam. So the imaging also will be dependent on that. I'm skipping this slide because it's just a repetition. For the management also, it has to be depending on the etiology. And most important thing, only one thing I'll tell you is that do the parental counseling, because there is a lot of anxiety, and that is extremely important for the family. And empirical antibiotics are not indicated. Okay, in fact, you can stop it for 2 days and just observe the child if it was really not indicated. if also started, you stop it and then you wait. Okay, it's not going to harm the child if something was started unindicated. Of course, antipyretics and hydration is important. Now, I'm sorry, madam, I took a bit more of time. So this is my take-home message or the reflection I had after making this PowerPoint, that we have to go through the stop, look and go approach. We have to do it as a multidisciplinary team. Because none of us we are not alone. We can always take help of our subspecialty colleagues. Always think about allaying parental anxiety. Thank you so much.
Thank you, dear Reepa madam. You had such a crisp and wonderful presentation. Would like to request, would like to invite Dr. Manish Jain sir for his expert comments. You can
Reepa,
stop
it was a
sharing.
Reepa, it was a good presentation.
Thank you, sir.
And the topic you had was a very pertinent topic, especially with the kind of viral infection going in right now. And as everybody knows, that fever is a very distressing condition, especially for the parents. So what I feel is the points you have covered very well, that whenever you have a fever, you should not jump onto the battery of investigations. You should wait. And more important than doing investigations and starting antibiotics is that you convince parents to talk to them. And in any fever, you can wait for at least 48 to 72 hours before starting any kind of antibiotics. And until unless you don't have any localizing sign, it is always better not to start antibiotics. And as you rightly mentioned, that one should check how the parents are measuring the temperature. Many times what happens is the method they are using to measure the temperature is wrong. So remember that documentation of fever is equally important rather than treating the fever. And as you rightly pointed out, that antibiotic stewardship needs to be there. There is no point in starting antibiotic right away when patient comes to you for the first visit. That is my message. Thank you. Good presentation, Reepa.
Thank you, sir. Thank you so much.
Thank you, sir. Now, I welcome our next speaker, Dr. Amol Murkute. He is pediatric intensivist from Nashik, Safalya Hospital. He is IIP ALS instructor. Welcome, Dr. Amol Murkute. And his topic is worm infestation in children.
Am I audible?
Yes, sir. Yes.
Yes, sir. Yes, sir.
Good evening, all of you. At the outset, I would like to thank MAHA-IIP and Women's Committee of MAHA-IIP for giving me this opportunity. The topic allotted to me was worm infestation, and I was actually confused what all to cover in this vast subject of parasitology in 8 minutes. As the entire slide is not moving.
Double
As
click
the entire
करो
world is fascinated by ChatGPT, I also asked ChatGPT to prepare a PowerPoint presentation on worm infestation. But luckily or unluckily, ChatGPT is still not empowered to make PowerPoint presentation. However, it did give me some key points which can be included in PowerPoint presentation. But then I thought, why to follow the artificial intelligence, and let us follow the human intelligence, which is way better than artificial intelligence. As far as worm infestation is concerned, 1/4 of world's population is affected. And India has been classified into the moderate risk area because the prevalence is 20%. And Maharashtra's prevalence is 29%. And as we all know, the commonest parasites are Ascaris and hookworm. So when do we suspect parasitic infections? Well, most of the time it is asymptomatic. However, some symptoms such as abdominal pain, intermittent diarrhea, vomiting, perianal pruritus, unexplained urticarial rash, chronic anemia with or without edema can give you a clue whether this child can have worm infestation or not. There are few non-specific complaints such as patient सांगतात नाकात बोटं घालतो, खूप गोड खातो, झोपेत दात खातो, चेहऱ्यावर पांढरे चट्टे आले. However, I could not find any substantial literature substantiating these non-specific findings to worm infestation. I have few constellation of symptoms and signs. Being specialist in childcare, we should not just look at the non-specific features, but we should give differential diagnosis to these constellation of signs symptoms. I will not say that worm infestation is the prime differential diagnosis for these symptoms. Maybe fifth or sixth down the line in your list of differential diagnosis, you can think of worm infestation. Sudden onset wheezing, dyspnea, paroxysmal non-productive cough, fever, X-ray infiltrates, apart from asthma exacerbation and foreign body, do think of Loeffler syndrome sometime. Papulovesicular rash on feet, urticaria, chronic anemia with or without edema, think of hookworm. Diarrhea, tenesmus, straining, rectal prolapse, think of trichuris dysentery syndrome, which is not very common although. And we all know this, focal seizures, which can be associated with hydrocephalus, transverse myelitis, visual disturbances, and retinal detachment. It is most of the time it is neurocysticercosis. Abdominal pain, mainly right hypochondriac, distension, tender hepatomegaly, vomiting with or without chest pain, hemoptysis, think of hydatid. And last but not the least, irritability, poor sleep, perianal itching, think of pinworm infestation, that is Enterobius vermicularis. Investigations usually don't help. Most of the time, the diagnosis is clinical and on science. However, most commonly we do stool examination for demonstration of eggs, larvae, and whole worm. Formalin ether method is one of the most commonly used method for the sedimentation and concentration of eggs. For EV, where the worms lay their eggs in perianal skin folds, perianal swab or a sellotape can help you demonstrate those eggs. Blood is mainly for anemia and eosinophilia. PCR is not yet standardized. Cost is a big concern. X-ray is usually meant X-ray abdomen, which is done for intestinal obstruction due to ascaris. And the typical appearance is cigar bundle appearance and whirlpool effect. Whirlpool effect is mainly in the barium meal. UAG is usually done for the hydatid cyst staging and neuroimaging for neurocysticercosis. The first X-ray is showing the air fluid levels, and on the left side you can see the cigar bundle appearance due to the bunch of worms and their radiolucency. On the right side there is a whirlpool effect on barium meal. Both these X-rays suggest intestinal obstruction due to bunch of worms, mainly Ascaris lumbricoides. The drugs commonly used are benzimidazoles, which are albendazole and mebendazole. Thing to remember here is that albendazole has to be prescribed with fatty meal. Nitazoxanide is also one of the very good drug, which is less commonly used. Piperazine citrate, pyrantel palmoate are the paralyzing agents, but the problem with them is their availability. Ivermectin is available, but it is available in combination with albendazole. And we should always remember not to prescribe ivermectin in kids below 15 kg of weight, because the safety and efficacy data for ivermectin below 15 kg is not readily available. So for round one and hookworm, drug of choice is albendazole followed by mebendazole, albendazole ivermectin combination or nitazoxanide. Nitazoxanide is available in Nizonoid tablet brand name. The strength is 500 mg tablet. For intestinal obstruction due to roundworm, we give piperazine citrate through NG for 2 days. It paralyzes the worm till the entire worm load is expelled. And for whipworm and EV, we use albendazole. So I have a couple of slides on NCC and hydatid. I am not going to cover their theoretical part. It is mainly the practical aspects while treating the cases of neurocysticercosis. For neurocysticercosis, the drug is albendazole, 15 mg per kg, 2 divided doses. The duration varies whether the lesions are single or multiple. Please do remember to start prednisolone 1 day prior before starting antiparasitic therapy and has to be continued in tapering doses for at least 2 weeks. Always do ophthal evaluation, because if the larvae are in the eye, the release of toxin due to antiparasitic drugs can give rise to blindness. And never start antiparasitic treatment with raised intracranial tension. It is contraindicated in such cases. Wait for ICP to resolve, then only you start the antiparasitic treatment. The important question to answer is when to stop anticonvulsants. And the AEDs are to be continued till the complete neuroradiological resolution. and the child is seizure-free for 6 months in solitary lesions. However, for multiple lesions, we take the period as 1 to 2 years. Surgical treatment is mainly for hydrocephalus in the form of ventriculostomy, VP shunt, even cystectomy can be tried in few cases. Hydatid is mainly caused by Echinococcus granulosus and multilocularis. There are 5 stages of hydatid. For early stages 1 and 3A, we do only medical treatment, which is in the form of albendazole. And for later stages of 1 and 3A with larger lesions, along with albendazole, we do one thing called as PAIR. PAIR stands for percutaneous aspiration, instillation, and re-aspiration. And by instillation, it is usually meant they instill hypertonic saline or absolute alcohol, and they re-aspirate it. It is usually for later stages of 1 and 3A. 2 and 3B need surgery along with albendazole and praziquantel. And for stages 4 and 5, if you can see in the classification, are usually inactive and degenerative stages. No treatment is required. Only thing which is required is periodic ultrasound examinations. So why do we deworm at regular intervals? It reduces malnutrition. It improves motor and language milestones. It reduces school absenteeism. It has impact on fitness, appetite, growth. The most important thing to note here is it does have impact on anemia in pregnancy and birth weight of child. The interval for deworming is 6 months if the prevalence is more than 20%, and it is yearly if it is less than 20%. So we Maharashtrians have the prevalence of 29%. That is why the deworming has to be done every 6 monthly. In 2015, Government of India launched this fixed nationwide deworming day. It is for all Anganwadis and school-based, for all kids between 1 to 19 years. It is conducted on 10th of February and mop-up is done on 15th of February. For states like Maharashtra, where the prevalence is more, biennial round is also conducted in August, which is usually on 10th of August. What they usually give is 1 tablet of 400 mg albendazole for kids more than 2 years. And for kids less than 2 years, it is half tablet. So with that, I end my presentation. I have not included any slide on prevention. The only thing which strikes me for prevention of worm infestation is hand washing, and hand washing. Thank you very much.
Thank you, Dr. Murkude, sir, for such a wonderful presentation. I would like to invite Dr. Manish Jain, sir, for the expert comment.
First of all, I would like to appreciate Dr. Amol for covering such a vast topic in 8 minutes and such crisp presentation. So probably he has covered everything with all the material available on worm infestation. And I totally agree with Dr. Amol that it is one of the underdiagnosed condition. And only way to prevent this is we follow regular government programs of deworming. That is the only way out. And just to mention about the investigations, various investigations were mentioned by Dr. Amol, but I probably feel that anemia and eosinophilia are the 2 basic investigations which should be done, and they are quite they're quite reliable to suggest the condition of deworming. And another topic, another issue, Amol, you said was the continuation of AED for, like you mentioned, that single lesion you go for 6 months, and if you have multiple lesions, you would like to continue AED for 2 years, sorry. So I think probably somewhere down the line, there is consensus that once you start AED, you have to have almost 2 years of seizure-free period before you start stopping AED.
Yes, sir. That's what I said, sir. Seizure-free period is 6 months or 1 or 2 years.
2 years. Yeah.
Yes.
Thank you, Amol. Nice to
Thank
meet
you.
Thank you, sir. Now over to Dr. Mangai for further session.
Thank you, ma'am. I think it's been a wonderful start. Commendable work by the speakers for managing to cover such vast topics in 8 minutes beautifully. We now move on to the third topic, another vast topic, congenital hydrocephalus. And for this talk, may I invite our speaker from IIP Kolhapur, West Zone, Maharashtra, Dr. Rahul Patil. He is a pediatric neurologist practicing in Kolhapur. Dr. Rahul. So, Dr. Rahul, please put it in the slideshow mode.
Sir, kindly unmute yourself. Yes, sir. It's full screen now. Kindly unmute yourself.
Good evening, everyone. Thank you, MyIP and MyIP Women's Committee for giving me this opportunity. Am I audible?
Yes, yes.
Yes.
Okay. So I will start the topic, congenital hydrocephalus. So first we will discuss definition of the hydrocephalus. It is increase in the fluid containing spaces of the brain at increased pressure, and which results from an imbalance between CSF production and absorption, or due to obstruction to the flow of CSF. So it is classified as communicating and non-communicating hydrocephalus, also obstructive and non-obstructive. But for this presentation, we will discuss congenital and acquired. So congenital, which is present at birth and often associated with developmental defects, and acquired, which occurs after development of the brain and ventricles. In newborns, the overall incidence is around 0.3 to 4 children per 1,000 live births, 4 cases of hydrocephalus per 1,000 live births. So CSF is mainly produced by choroid plexus, 50 to 80%. Then also extrachoroidal CSF production also occurs in subarachnoid sites and also by way of transependymal route. And it is absorbed into the vascular system mainly through the arachnoid villi covering the brain and spinal cord. So approximately 55% of all cases of hydrocephalus are congenital. And different causes are there for congenital hydrocephalus. First is the congenital aqueductal stenosis. And it results from an abnormally narrow aqueduct, which is often associated with branching or corking of the aqueduct. And in small percentage, it is inherited as X-linked aqueductal stenosis. Then second cause is posterior fossa malformation. There are Chiari-2 malformation and Dandy-Walker malformation. There is a difference between Chiari-2 and Dandy-Walker malformation. Chiari-2 malformation has a foreshortened occiput, and Dandy-Walker malformation has prominent occiput. In Chiari-2 malformation, there is fourth ventricle outlet obstruction with displacement of impaired vermis, pons, medulla, and cervical canal. And in Dandy-Walker malformation, there is cystic expansion of fourth ventricle and midline cerebellar hypoplasia, and that was associated with atresia of the foramen of Luschka and Mezenki. Then third cause is neural tube defects. Hydrocephalus occurs in approximately 80 to 90% of patients with meningomyelocele. And of these cases, 50% are obvious at birth. There are different other causes also, that is agenesis of the foramen of Monro, congenital tumors, arachnoid cysts, then vein of Galen malformation, and intrauterine toxoplasmosis. So clinical features. Most of the hydrocephalus patients present as acute raised intracranial pressure symptoms, but because of the relative distensibility of the infant skull, the presentation is more subtle in infants. They present with failure to thrive, delayed development, sometimes irritability, poor feeding, vomiting, apneic spells, episodes of bradycardia, then tense anterofontanally, macrocephaly, distended scalp veins. In advanced cases, we can get massive signs like Crampford percussion note, setting sun sign, and pyramidal tract signs also we can get in lower limbs in hydrocephalus patients. So diagnosis. So how can we diagnose neuroimaging? So first is the cranial ultrasound. It is the quickest, least expensive, and most convenient method to demonstrate ventricular enlargement through open anterofontanally. But it has limitations. It may not visualize posterior fossa well and do not always establish the etiological diagnosis. Then CT, it also shows ventricular size and morphology and also presence of periventricular lucencies, but it has also limitations. It is exposure to radiation, particularly with serial CT imaging, and it may not always reveal the underlying cause of hydrocephalus. MRI remains the most important investigation to diagnose the cause of hydrocephalus and also morphological definition of hydrocephalus. And it is also better for evaluating Chiari malformations or aqueductal stenosis also. So how to manage hydrocephalus? In infants and children with symptomatic or progressive ventriculomegaly, CSF shunt is needed. And most commonly used shunt is the PP shunt. In patients with obstructive hydrocephalus secondary to a mass, there is restriction of the mass, and there will be no need of shunt. Observation. A trial of observation or medical management with acetazolamide may be indicated if no documented obstruction or no operable lesion is present, and the hydrocephalus is mild and slowly progressive, or arrested hydrocephalus, in which the CSF pressure has returned to normal and there is no pressure gradient between cerebral ventricles and the brain parenchyma. So these patients should be followed carefully with neurological examination, neuropsychological assessments, and careful assessment of their development. And a shunt will be necessary if there is any deterioration of above parameters. So what are the complications of shunt? Their main two complications, that is occlusion and bacterial infection. Occlusion can cause headache, papilledema, vomiting, mental status changes, and bacterial infection with most probably occurs with Staphylococcus epidermidis, and it may cause symptoms of meningitis. So prognosis of hydrocephalus. The neurological and intellectual disabilities depends on etiology and degree of hydrocephalus. It also depends on cortical mental thickness, but etiology and degree of hydrocephalus is more important. Requirement of shunt and presence of other brain anomalies also decides the neurological and intellectual disabilities. Disabilities and IQ is less compared to normal children, and there also occurs visual problems like strabismus, visual field defects, and optic atrophy in long term. So prevent in some cases. So prevention, to some extent, we can prevent with folic acid supplementation of women of childbearing age to prevent neural tip defects and associated hydrocephalus. Then antenatal screening for hydrocephalus and congenital anomalies, especially USG, and if required, fetal MRI, and it can give option of termination of pregnancy. And genetic counseling in case of X-linked in future pregnancy, in case of X-linked acute stenosis, there is L1CAM gene mutation that we can detect, and we can use genetic counseling for future pregnancies. Thank you.
Yeah, Rahul, it was a good presentation and you covered the topic very well. And as you rightly pointed out that there are various congenital malformations that can lead to hydrocephalus, but at the same time we need to keep intra-uterine infections in mind, because many times those causes are not looked for. That is one thing. And another thing as far as progression is concerned is that early diagnosis and early intervention is the main point that can salvage the brain matter and probably the further outcome of progression of the child. But still at many places in our country, early intervention is not available. So that is one of the drawbacks. But you should diagnose it, try and diagnose it as early as possible and intervene as early as possible. And what we have seen in our practice is the management of shunt. Parents should be taught about how the shunt is to be managed. How do they check for the patency of the shunt? Because shunt infection and blockages are very common, and that can again lead to further deterioration in condition. That is it. Thank you, Rahul. Good presentation.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you, Dr. Jain. Thank you, Dr. Rahul. We now proceed on to the next topic. The fourth topic today is intussusception in children. And our speaker is Dr. Anis Syed. He's from IIP Buldana, Vidarbha Zone. Dr. Anis is President AOP Buldana, and he's practicing since 2007 at Mamta Hospital and Diagnostic Center, Buldana.
Hello.
Dr. Anis, you may please start your talk.
Yeah. Can you hear me? Hello.
Yes, sir. Yes, sir.
Yes.
Yeah.
Yes, we can hear you.
And my topic is intussusception in children. As the name suggests, intussusception, that is intrusion of something. So my questions are: what is intussusception? What is it? How it happens? To whom it happens? What is the danger? How to solve the problem? And can I avoid it? So intussusception occurs mainly in, as the name suggests, it is the part of alimentary tract. So intussusception is the telescopic invagination of distal segment into proximal segment of the intestine. What happens when something goes wrong in the peristalsis? one part of the intestine, it telescopes into the another part of the intestine, and which causes intussusception. So what is the cause? Approximately 75% cases are idiopathic, most common in 3 months to 5 years age group, and it is related to the seasonal infections. It has seasonal variation, such as viral infections caused by the enteric adenovirus, which cause lymphoid tissue hypertrophy and which results in the intussusception, mostly in the terminal ileal area. So this intussusception, it deals with 2 points: intussusception with lead point and intussusception without lead point. So we will cover in the next slide. But what is the presentation of intussusception? Firstly, the intense cry of the child, intense, intermittent, frequent cry associated with lethargy, red currant jelly stool, intestinal polyp, Meckel's diverticulum, and contrast enema. These are the 5 pictures which revolves around the intussusception patient. So what is the presentation? Usually any infant who comes with sudden onset of colicky abdominal pain or excessive inconsolable cry with episodes of silence in between, and he has vomited with some amount of lethargy. Mother says that the child has become somewhat limp. There is some amount of hypotonia and his consciousness has been altered. And this all happens in a very acute episode associated with sweating, pallor, shock, and later the mother says that he also has this reddish colored stool and then decreased urine output. So all this presentation part is there. So this is the red currant jelly stool, reddish stool attached to the diaper. So how do we diagnose this intussusception? Mainly this is the clinical part through the history, but some cases are very typical and some cases are very atypical. So in diagnosing typical cases, we don't face any problem, but in cases of atypical presentation, we have to take the help of some investigations and help of experienced radiologist. If diagnosis is unclear, then we go for imaging, mainly ultrasound, and then CT scan if needed, if we are thinking of any lead point. Investigation part, blood investigation do not show any much abnormality, such as CBC may show some neutrophilia or CBC may be normal, but mainly X-ray abdomen standing shows dilated gas-filled bowel loops, paucity of gas, and air fluid levels in later stages. USG abdomen, which is the main investigation, which we usually order, shows the target sign, bowel in bowel appearance, and practically it is the investigation of choice. Bowel enema, barium enema has been the gold standard, but air and water double contrast enema are available now, and the choice is left to the surgeon. So this is the ultrasonic view of bowel in bowel appearance in a case of intussusception. Here in cross-sectional view, we can see loops of intestine in another loop. So this is the bowel in bowel appearance. Now regarding enema, there are 3 types of enema to reduce it: pneumatic, hydrostatic, and barium enema. Barium enema has been the gold standard. Then next one is the hydrostatic, which has some pros and some cons, but currently preferred enema to reduce the intussusception is pneumatic, because it has very less chances of complication. How do we manage this case? First, initially we have to take the vitals of any baby who is coming with the suspected diagnosis of intussusception, sudden intense cry, and we are thinking of it as intussusception. Then we have to take the vitals, put the venoline and nasogastric tube placement for the decompression of the abdominal contents, IV fluids for dehydration, and IV antibiotics empirically we have to start. And once we think of intussusception, we have to urgent surgeon's referral has to be done. Stable patients with no signs of bowel perforation, as suggested by the clinical examination, should be treated with non-operative reduction. Hydrostatic or pneumatic pressure enema has high success rate in stable child. In cases where we cannot go for the non-operative reduction, laparotomy is indicated when the intussusception patient has peritonitis, perforation, or he has the prolonged history of more than 48 hours or 72 hours, or there is any high likelihood of pathological lead point or the failed reduction through enema. So all these cases of intussusception, we have to think of some uncommon points, such as in any patient of gastroenteritis, if he comes with this sudden pain, the nature of pain has changed, or the consistency of stool has changed, or the color of stool has changed, or the child has not passed stool, and after PR examination, we are getting some amount of blood on the PR examination, we should think of intussusception in any case of gastroenteritis, whether he is admitted or not admitted. So this is the presentation from my side. Thank you very much.
Thank you, Anish sir. It was a nice presentation. Though it is not a very common condition, but a very subtle condition, because if not treated in time, it may patient may deteriorate like anything. And once who has seen a patient of intussusception, I think we can never forget the patient. And as you rightly mentioned, that history part for abdominal examination and for rectal examination is the most vital and crucial part when we deal with intussusception. And many a times, most of the conditions are self-limiting or self-resolving. But once you diagnose, I think what kind of enema is to be given, whether the surgical intervention is to be taken or not, I think it would be a surgeon's call rather than a pediatrician's call. This is what I personally feel. Thank you. All in all, a good presentation, Dr. Anish.
Thank you, sir. Thank you. Thank you.
Thank you, Dr. Jain. Thank you, Dr. Anis. Our today's Tuesday Takes bullet train has finally come to the last station. That is our last talk for today. And for this, I would call Dr. Nachiket Inamdar. He is from IIP Dharashiv, Marathwada Zone. Dr. Nachiket has a fellowship in neonatology. He is currently practicing at Samarpan Children's Hospital, Dharashiv. He will be talking on iron deficiency anemia. Dr. Nachiket, you can share your slide.
Yeah, I hope I'm very well audible to all of you.
Yes,
You're audible. Sir.
Yes.
And my slides are also visible.
Make full screen.
Yeah, right.
Yes, yes.
At the outset, I would like to thank my IIP and Women's Committee for giving me opportunity to deliver this topic in this forum. Considering the time allotted to me within this stipulated 8 minute times, to present this iron deficiency anemia is very difficult task, but I try to be brief and highlight the points which are very much important. During the presentation, there are some tables which are busy also, but I will highlight which is important in our day-to-day practice. If we see the prevalence of anemia throughout the world, what WHO stated is the most common nutritional deficiency in the children. And if we see this world graph, almost the Asian countries and the African countries where the prevalence is more than 40%, and it is supposed to be very severe public health problem. If we consider this prevalence in our India, our own statistics says when there is a National Family Health Survey during the year of 2015-16, it is 59%. And what are the approaches are being performed to decrease the anemia prevalence in India? They are futile, and this raised alarms, and even the prevalence is increased from 59% to 67%. And this is the same for Maharashtra also. For pediatrician like us, what is important is the highest prevalence we found in the children's less than 5 years of age. If we see the definition, actually before going to the anemia, the iron deficient state is very important, and it refers a state in which there is insufficient iron to maintain the normal physiologic function. If we see the laboratory parameter for that, which is a serum ferritin, which is a reliable indicator of iron store in the body, if it is less than 12 microgram per liter in the children less than 5 years, and less than 15 microgram per liter in more than 5 years, then it is to be called as an iron deficient state. While the anemia is a latent stage, where the hemoglobin concentration is more than 2 standard deviation below the mean reference value for the age and sex matched healthy population. For this, we have the cutoff for the different age. If we see a child with a 6 months to 5 years, if less than 11, it is to be called as anemic. For that, between the 5 to 11 years is less than hemoglobin less than 11.5. For the age between the 12 to 14 years is less than 12, and for the adolescent is that 15 to 19 is for the girls is less than 12, and for the boys is 13. Though these are the statistics from the overall world, for India we say that the cutoff level is 1 to 2 gram lesser than that. In our practice, we see a child with a CBC and hemoglobin count of 9 and 10, we should be very much cautious, because the child already is anemic and he has already depleted his iron stores. So what is the pathophysiology? As we all know, the iron is very essential micronutrient, and it is involved in various metabolic processes like oxygen transport, electron transport, and DNA synthesis. It is important component for the cellular proteins and enzymes. Most of the iron is stored in the body in the form of heme proteins like hemoglobin and myoglobin. 1/4 is stored in the form of ferritin and hemocytin, and a lesser amount of approximately 3% in the catalase and cytoplasmic enzyme system. How the iron is absorbed from the gut? It is usually absorbed in the duodenal part. There are two hemoglobins like the sources of iron, that is the heme source and non-heme source. Heme source usually found in the meat and fish, and it is highly absorbable, and it is not dependent on any factor. However, the non-heme iron, which is present in the most of the vegetables, milk and egg, but it is only 10% absorbed. And there are multiple factors which its absorption is dependent. Like there are some absorption enhancers like meat, fish, amino acids, ascorbic acid, while the fibers, fats, soya proteins, egg phosphoproteins, the phosphates and calcium in the milk, tannin and phenol found in the tea, coffee, they inhibit the absorption. So the iron in the body is tightly regulated. If we see the daily requirement for the iron, for the infant is only 0.6 mg per kg. For that, a pre-adolescent children is 0.8 mg per kg per day. For adult male is 1, and for adult female is 1.5 mg per day. So what are the mechanisms to have an iron deficient child? So there are different ways. In any child, a single component will present, or there are the multiple factors also. If we see for the decreased dietary iron supply, this may be present in the premature baby, because iron is mostly transferred from the mother to the fetus in the third trimester. If a child has iron deficient feeds, a late weaning, and a vegetarian diet. And surprisingly, a patient came in today. The mother is very happy today, and ती सांगत होती माझं बाळ खूप मोठा आहे, सगळं पायावर सूज आहे, पोटावर सूज आहे, but child is very much anemic, and she happily saying that we are giving 1 liter of cow's milk to him. This is actually a condition in our Indian society, and that is one of the reasons leading to the iron deficient child. What are the other reasons that increase the iron demands? Like in the infancy, where there is a rapid growth and the demand is not paid by the adequate iron supply. In the child, like a low birth weight child, and in the adolescent when there is a pubertal growth force. There are other causes when the iron absorption is reduced. There are various food inhibitors, as we discussed previously. There is infection like Helicobacter pylori infection, chronic abdominal gastritis, which also delay the gastric emptying, increases the pH in the acid, and that also inhibit the iron absorption in the duodenum. The inflammatory bowel disease like celiac disease also decreases the intestinal iron absorption. There are also another component, the blood loss. The cow's milk protein intolerance leading to colitis and acute blood loss, this is also the very important reason in cow's milk, the baby who have the anemia. The other important cause in India is the intestinal parasitic infestation. The Meckel's diverticulum, inflammatory bowel disease. In adolescent age group, the menstrual blood loss and bleeding diathesis. If we see the clinical manifestation, there is a slow occurring pallor is present, and the nails there is a cholinergia. But before that, there are other symptoms also present because of the iron deficiency. Like the child has a decreased effort capacity, he has an exercise limitation. In the gastrointestinal system, there is a loss of appetite, angular stomatitis, atopic glossitis is there, dysphagia. There is a eating of a non-dietary iron like pica, and phagophagia is there. In severe anemia, there is an increased cardiac output, tachycardia, and in severe anemia, there's chances of heart failure also. At the same time, such children are have increased chances of infection because of the T lymphocyte and leukocyte dysfunction. There's a defective production of interleukin 2 and 6 that all overall leads to the increased susceptibility to infection. But at the most, the central nervous system is affected at the early, and there is a neurocognitive psychomotor impairment which might be permanent for such child. The child is irritable, malaise, they are restless, they have the fainting episodes. We all know that there is a severe iron deficiency anemia associated with the breath holding spells, febrile seizures also. These children are attention deficit, they have learning difficulty, and they have behavior disorder also. They have the decrease in perception function, retardation in the motor and mental development. There is also in the chronic stages, there is a papilloedema and sort of a cerebral. When we suspect anemia with history, proper history, we do investigate inside, and our first investigation choice is the CBC. So accordingly, there is a hemoglobin and hematocrit is low for the age and gender with low RBC count. But the most important is the mean corpuscular volume and mean corpuscular hemoglobin, which is less than 70, MCV and MCH is less than 30. But the MCSC is normal or decreased. Because the RBCs are, they have the differentiate hypochromic and microcytosis, the RDW is increased. And because of the mimicking erythropoietin to thrombopoietin, the platelet counts are increased. The Messner index, that is MCV, is more than 30. And this is very important to differentiate, is a close diagnosis from the thalassemia trait, which is also very common in India. And the approach to thalassemia trait and identification is very much different. If we see the peripheral smear, there is a hypochromia, microcytosis, anisochromia, anisocytosis. Rarely we can see the basically stippling, target cell, and hypersegmented neutrophils. But even if the diagnosis we can confirm, if we give a trial of oral iron, the dose of 3 mg per kg elemental iron per day results in the hemoglobin rise of more than 1 gram per day within 4 weeks for a child with mild anemia, and within 2 weeks for a child with a severe anemia. That we can diagnose the child as an iron deficiency anemia. There are some confirmatory tests where there is an iron deficiency state can be diagnosed with the markers like serum ferritin, which should be less than 12 microgram per liter in the child less than 5 years, and less than 15 microgram per liter more than 5 years. But it should be cautious because serum ferritin is an acute release of phase protein, and it is increased in very much infections and in inflammations. The next marker is transferrin saturation, which should be less than 12%, 14%, 16% as per the age limits. And later stages, we have the serum iron less than 35 microgram, and there is an increased total iron binding capacity. Just to enumerate the newer tests, we can diagnose the iron deficiency anemia, that reticulocyte hemoglobin contained or reticulocyte hemoglobin equivalent test, the percentage of hypochromic red cells, that hypo percentage, soluble transferrin receptor, and free erythrocyte protoporphyrin level. If we see the changes of these laboratory markers during the evolution of anemia, in the pre-latent and latent only we can see the serum ferritin and iron store are decreased. While in the evident iron deficiency anemia, all the CBC markers, the CBC and RBC indices are decreased. So that is one of the important. So how we can proceed for the management of such child? So initially the supplementation we can give in the full-term breastfed child, starting from the 4 months of age, like 1 mg per kg per day, maximum 15 mg, till the child infant reach have a sufficient iron-rich complementary food. And for the premature breastfed infants, we can start as early as 2 weeks from 2 weeks of the age in the dose of 2 to 4 mg per kg per day throughout the first year of life. Those who have a evident iron deficiency anemia, we can start in the dose oral iron in the form of 3 to 6 mg per kg elemental of iron daily. And duration, it should be at least 8 to 12 weeks after the desired hemoglobin is reached. So once the hemoglobin is reached to above the desired level, to replenish the iron stores, we have to give further for the next 2 to 3 months. Parenteral iron therapy we can use, but cautiously and in only some instances, like when there is a severe form of anemia where the patients are intolerant to oral preparations, there are poor response, poor absorption and compliance to oral drugs, and diseases when the iron is not absorbed from the gut, like celiac disease. The forms available, we have the low molecular weight iron dextran and ferric carbohydrates. So this size is very important when we diagnose the iron deficiency anemia, which oral iron preparation we should use and what are their advantages, disadvantages, what are their costly. So we do usually give the iron salt, which is very commonly used. We have the iron salts like ferrous sulfate, ferrous ascorbate, and ferrous ammonium citrate. And depends on the elemental iron percent, we do give dose in the elemental iron. Their availability is good, but the main disadvantage is that they decrease, their absorption decreases with the dietary inhibitors. They are cheaper, easily available, and most of the government outside they are available in ferric ammonium citrate form. But the side effects are oral iron salt. They are the GI side effects like vomiting, nausea. There is staining of the teeth. Most common constipation, in some cases diarrhea also. And if these iron salts are mistakenly taken by overdose, they also cause the acute toxicity. This is also should be kept in the mind. So the other preparations of iron, like iron polymaltose complex, which is elemental iron, which is the 5 ml of 50 mg.
The time's up.
Yeah, the only one slide, man. It has no relation with the food or milk. They are lesser GI side effect compared to iron salts, and there's low rise on the hemoglobin. The newer the carbonyl iron formulation, this is highly purified metallic iron, because this can be used in the food fortification. It is less toxic, but it is costly. We have the colloidal iron, which is present in the 5 ml 80 mg. Availability is good, the cheaper, but it do have the GI side effects. And the newer version is the liposomal iron, which has the ferric diphosphate. This absorption is also very good from the duodenum, not affected by any food inhibitor. There is no staining and there is a lesser side effect. And without completing, the newer approach is the intensified National Iron Plus initiative. So to decrease the prevalence and to dream a country with the anemia mukta Bharat, we have the life cycle approach. So all pediatricians should have this approach with the charging of food, the iron supplementation from the age of 6 months to 19 years for the boy and till the adulthood for the girl. The risk assessment is very important. Those child who have increased chances of iron deficiency anemia, their screening from the 6 months of age. Dietary advice is very much important, like exclusive breastfeeding, supplementation of iron fortified food, practices such as delayed cord clamping, and treatment of infection and parasitic infestation is very important. We have in the government setup, the iron folic acid supplemented for the 6 months to 5 years, which can give the twice a week in the form of fixed dose combination and deworming every 6 monthly. And for the more than 5 to 10 years, once a week, we can give. So, thank you for the hearing.
Yeah, I must agree, Dr. Inamdar, that you were given a tremendous job to cover one of the most common and prevalent condition in our country in 8 minutes. And you did that job absolutely very nicely. And one thing everybody should remember is that association of iron deficiency anemia with hemolytic diseases. Now, hemolytic diseases is one of the areas where usually people don't consider that there may be coexisting iron deficiency anemia. So most of the patients are treated like in our area, in Vidarbha, sickle and thalassemia is very common. We have seen that most of the patients are being treated for sickle cell and thalassemia, but there is no consideration or even effort to look whether there is coexisting iron deficiency anemia or not. So that is one area one should be cautious about the iron deficiency anemia. And other thing you rightly pointed out that we need to have a multi-pronged approach that includes dietary supplementation plus regular deworming. So all these things need to go hand in hand to prevent this condition. And another important aspect I feel is that especially the side effects of iron should be very well clearly spelled out to parents in detail, because those are one of the most common causes which leads to stoppage of therapy without informing anybody. So whenever we put a patient on iron therapy, parents need to be counseled about, especially about the side effects of what are the possible toxic effects of iron therapy. Thank you, Dr. Inamdar. Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Jain, for your expert views on this topic, and thank you, Dr. Nachiket, for your wonderful talk. All the speakers today have done due justice to the topic and to the time allotted to them. All of them have finished well in time. I now request Dr. Sonali ma'am to please take this session forward.
Thank you, Dr. Mangai. It's almost now the end of session. Any questions are there for the speakers? They will answer you.
I have a question for Dr. Syed, Anis Syed.
Yes,
Can you hear me? Hello? I'm Dr. Gosavi here.
Yes,
Yes,
sir. Yes,
sir.
sir.
Yeah.
You are audible.
Yes,
Ah,
Yes, sir.
Dr. Syed,
Yes, sir.
you talked on interception. Enoxaparin purpura presenting as acute abdomen
Yes, sir.
turns out to be, we initially think that it's a surgical case. What
may-
I'm talking about enoxaparin purpura presenting as acute abdomen turns out to be interception.
Yeah.
A few words on that from your side.
Sometimes, sir, what happens? Intussusception with lead point and intussusception without lead point, we categorize intussusception in these two cases. But sometimes HS purpura, as we see, there are some kind of hemorrhages in the intestine. And in those cases, if a patient has joint symptoms, but it's sometimes accompanied with some kind of intestinal hemorrhage that causes some amount of peristaltic dysregulation in the intestine, which causes the intussusception.
Yeah, I just want to say,
There is one case when I was in the undergraduate in my college, and the patient of HS purpura, he came, and on day 3 of admission, he had some amount of abdominal distension, and it turns out to be an intussusception.
yeah, just imagine a surgeon inadvertently opening the abdomen in a HSP case for interception. That's just I wanted to point it out. So you have to be very careful. I mean to say is you should be back of your mind. A pain in acute abdomen, suspected interception. HSP is one of the medical problems
Yes.
you might have facing.
Yes, sir.
That is what I want to point it out.
Yes, sir. Yes, sir. Definitely.
Yeah. Ramakant is smiling at me.
Yeah, we any interception beyond 18 months or 2 years should be really thought and with pinch of salt. And most of the time it is with the lead points.
Correct.
And we had a common case with Dr. Gosai and myself. We had recurrence of interception
Yes.
and interception occurring in 9 years old girl. Second time she had interception operated, and on 5th post-operative day, the girl had typical palpable purpura.
Correct. That's why I
So-
said variant of HSP without
Yes,
rash.
interception beyond 18 months,
Yeah.
you
Yeah.
should have their antenna to be raised and should look for the cause rather than it is because of gastroenteritis, which is one of the most common is called. And I, at the same time, since we are on the question with Dr. Syed, I forgot to take your name, but your topic was excellent and you did excellent deliberation. So how will you advise to deal with the pseudo interception, which is with high frequency probes? It is reported every now and then. How to decipher on that?
I didn't get you, sir.
Pseudo interception, most of the time patients are having pain in abdomen, loose motions, and bowel in bowel pathologies most of the time is reported as interception by sonologist because of very highly sensitive probes, and whether it is bowel in bowel or whether it is an intestinal edema which is giving rise to that picture. So how will you like to differentiate the pseudo interceptions?
Sir, initially, if any patient comes with the history of intense abdominal pain, and we did ultrasound, and on ultrasound, the sonologist gave us the picture of bowel in bowel or loop in loop appearance, query interception. In that case, based on the clinical findings, whether the child is very stable or not, I would like to wait for the 24 hours. If he develops any kind of deterioration in his health, such as the downgoing vitals, downgoing pulse, down and weak or 3D pulse, and if he's developing decreased urine output, distension of the abdomen, and downgoing the consciousness level, in that case, I will go for the surgeon's opinion. Or if the child is going stable and if the child is doing well in those 24 hours and his abdomen is soft, he's passing stool normally and his urine output is good, then I will be rest assured that this is pseudo intussusception and is not going to harm him.
It is very tricky job, I understand, because we on one side we don't have resection anastomosis by delaying for 24 hours, observing, sitting on the case for 24 hours, because we will be having a risk of doing a resection anastomosis. Bowel may get gangrene and may not have that blood in stool, hematochezia. But it is a difficult situation. It should be a case to case. It will be an individual experience. And I think to err on positive side might be the solution, to have adding the head together, have earlier opinion of surgeon. And if he feels that he can do the reduction, hydrostatic reduction, and if he feels that no, it is not possible, or repeat sonography many times helps us that this bowel and bowel is not visible. So repeating sonography, if we are having slight doubt in mind after 6 hours or 4 hours, rather than waiting for 24 hours, will guide us better in such cases.
Sure.
Thank you. I have got one question for Amol. Amol, I'm impressed with ChatGPT.
Thank you, sir.
It was wonderful. And I liked your presentation. It was too excellent and very well covered.
Thank you, sir.
I just wanted to know, how will you choose praziquantel or albendazole? That is one, in case of neurocysticercosis, or the same. And second is there a role of albendazole other than neurocysticercosis for 3 days, 5 days, or 7 days? Or should it be only once?
Praziquantel is a good drug, sir, but availability is a problem.
Yeah.
And albendazole for 3 days, apart from NCC, I will think of hydrated. And for resistant cases such as enterobius, we can think of giving for more days.
Okay. So as on date, Government of India and in our state, we are going to give a single dose every 6 months.
Yes, sir. Yes.
Yeah, very sure about heavy. We may think of 3 days or 5 days.
Yes, sir.
Yeah, I got one more question to Dr. Inamdar for iron deficiency. What is the frequency of iron administration? Should it be once a day? Should it be once in 2 days? And whether hepcidin has got any role to play in this, or whether it is just to differentiate from the inflammatory biomarkers and
the oral iron preparations, sir, like the iron salts, okay, because they usually get inhibited by the various food inhibitors. Okay, so giving rather than multi-dose, we can give a single dose and to be taken at an empty stomach, their absorption definitely is going to increase. And if we administered it with the like as vitamin C, like fruit juices or the orange juice, the absorption definitely will going to increase. But this is not the same with the newer iron preparations, where they cannot be dependent on the food inhibitors, like the newer ones, the liposomal iron. And as we know, the hepcidin plays a negative role in the iron absorption. When there is an increased iron intake from the duodenum, the hepcidin plays a key role, and that negatively impact the iron absorption from the duodenum.
So, will you recommend once in a day or once in 2 days?
It's depend on case to case studies, sir. How the child is taking, how he is developing the GI side effects, and how the parents are complaining. Because
preemptively, because there is no question of multi-dose. It will be only once in a day, or whether it will be once in 2 days, like that. Preemptively, without any, we are knowing patient has come first time.
So it is better to give it that's twice a day. Twice a week. So the hepcidin will not play a role in the decreasing the absorption of the iron.
Okay, thank you so much. Wonderful. And it was very wonderful presentation. and very good points were suggested commented by Jain sir, Professor Jain sir. Thank you, and it was a very nice presentation on PEO. Thank you. And I just wanted to know from Amol, how many times because standalone ivermectin is available, as I should not be taking trade name, but Vermact, which is available as 6 milligram and 12 milligram.
Okay.
So yeah, without isolated ivermectin is available. So other than scabies, have you ever used it in as a deworming agent?
No, sir, I have not used it, but the literature do mention its use for strongyloid stercolis and the cases of Ascaris or hookworm which are not responding to albendazole alone. But I have not used it, sir.
And availability of nitazoxanide?
Nizonide tablet is available, sir. Some 150 rupees ka strip, and 500 mg is the strength, sir, of each tablet.
Nitacure and Nizonide. Yes.
Vibor writes it quite frequently.
Yeah, but
Vibor writes it quite frequently, sir. Borkar.
Yeah, particularly this is very wonderful drug for chronic diarrhea. Many times we give preemptively. Many times these are the sporidium which responds very well to nitazoxanide, and many times we do not find any. So, but suspension previously was available. Now only 500 mg Nitacure and this thing. I was asking about the suspension, whether any suspension is available, any brand name. Nitacure
No,
and
sir, I am not aware, sir. Yes, sir.
I should give chance to others to ask questions. Thank you.
Thank you, sir.
Thank you, sir. I felt like President taking viva of all speakers.
As usual.
Similar experience in Bangalore, when Dr. Kishore Phadke was taking, there was no slide on panel discussion. Nothing was there. And in Bangalore, this thing, there, Karnataka Pedicon. And it was a similar experience. I said, I thought I should give some taste of it to today's presentation, because these are the very young lot. And I'm so happy that these are so well prepared, their diction, their delivery of the topic, their in-depth knowledge and preparation was just fantastic. I'm impressed by everybody's preparation. And it is nice to see my friend Dr. Sanjay Gosavi, even in virtual.
Ramakant.
Yes.
Yeah. It's not a question. I'm just want to comment looking at you. You often say congenital hydrocephalus, right? Head circumference, हेड सर्कमफ्रेंस मॉनिटरिंग, एंथ्रोपोमेट्री लेते चलो, हेड सर्कमफ्रेंस लेते चलो, जब भी मौका मिलता है और प्लॉट करो तो जल्दी ध्यान में आएगा, राइट? सो रेगुलरली हेड सर्कमफ्रेंस ईमानदारी से लेते रहना.
Any disproportionate,
it's not a comment on anybody, just
any disproportionate rise in head circumference, if we do this anthropometry more than 2 centimeter per month, it should and you should be doing
earlier the diagnosis, that will be better.
Earliest measure is sonography doing for congenital hydrocephalus. Thank you for your
early suspicion. Yeah. Yes.
There is one question for Dr. Inamdar seen in chat box. Calcium and iron supplement can be given together. How much difference should be kept between these two medicines?
No, as we see that usually the calcium impairs the iron absorption. So it should not be given together at all. Okay, that is the reason one of the calcium in the milk inhibit the absorption from the iron. And the iron calcium it should not be given simultaneously. That is the one reason. And the gap, when there is a gastric emptying and duodenal emptying, almost minimum 2 hours gap should be there between the two if we had to.
Okay, so thank you. Any more questions?
I have got one question to Amol again. Whether the app is available or you have to just Google it or Safari it or Bing it.
No, you have to log in with your Gmail ID, sir. Sign up.
Yeah.
And I tried daily, sir. I asked him to write a poem on Tendulkar,
and he wrote it in it wrote it in 2 minutes, sir. Anything which
Wonderful.
you wish for, it can be done on ChatGPT. But we should not be slave to the artificial intelligence. That's what I feel.
Wide implications. You just put in a city and it gives you 4 days, 5 days, 10 days, and it gives you a total program how to you roam around in the city. Wonderful.
Yes.
So there is no app yet. You have to log in.
Log in
One
on
of-
website, sir.
Yeah, website. So any this in browser for that.
Yes, any browser, any browser.
Yeah. Wonderful.
Thank you.
But hello, sir. There is one preparation for nitazoxide, nitazox. I've got syrup uracil. And Swift company has, but it has only 100 milligram 5 ml. Nitazox syrup is available.
Syrup was available like this only in Nitacure, Nizonide.
Nizonide also.
Yeah, Nitacure
And
also is
250 milligram tablet also is available. 250.
100 for 5 ml and 500 mg tablet. Previously, even 250 mg tablet was also. But nowadays, because not prescribing, what has happened to many drugs, this Nitacure is not available, or syrup suspension is not available. It is only the tablet. But nice, you brought the sample itself.
Yeah, it is there available.
Thank you, ma'am. Thank you.
Company
Thank you. And Swift.
manufacturer.
And Swift. And Swift. Okay, sir. Very excellent presentation, all speakers. Fantastic.
Yes.
And very good guidance from Manish sir and Ramakant Patil sir. Excellent. Amol sir, thanks. Sonali, thanks. Good.
There was no guidance from me. I was satisfying my queries.
But sir, we were learning from it. From that queries, we were learning.
And it was very nice to see Manish sir, even if virtually. I did meet him 2 years back, but it was nice to see him. And very good input, sir. Thank you.
Thank you, sir. Thank you very much, sir.
Congratulations, dear all speakers, for your wonderful presentation. Now we are at the end of session. Would invite Dr. Neha Singh, our co-chairperson of Women's Committee, for the vote of thanks. Before that, Amol sir, you want to say something?
Tomorrow is journal journey session. So
Okay.
those interested, or I request all to attend. Without the journal journey is without any MMC points.
Yes. Okay, thank you. Over to you, Neha.
Yes, thank you, Sonali ma'am. Being the co-chairperson and on behalf of MahaIP Women's Committee, first of all, I would like to thank our MahaIP President, Dr. Ramakant Patil sir, and our Secretary General, Dr. Amol Pawar sir, for giving us their support and MahaIP platform. I would also like to thank Dr. Manish Jain sir for accepting our invitation for being the expert for today's Tuesday Take program. Sir, your expertise, comment and guidance, which were very useful. Thank you, sir. I thank Maharashtra Medical Council and our MMC observer for today, Dr. Sanjay Gosavi sir, for giving us 2 MMC points. Sir, thank you for joining and also your active participation in the program. I would thank all the 5 speakers of today for preparing and delivering their topics fantastically and doing it so nicely in a very short duration. You all were excellent today. Also would like to thank our Women's Committee Chairperson, Dr. Sonali Shivate ma'am, Dr. Manjusha ma'am, as well as other members of Women's Committee for helping in organizing today's program. Thank you, Dr. Renu Boralkar ma'am, for starting this wonderful Tuesday Take last year and joining today for cheering all of us. And I would thank Sonali ma'am, Dr. Mangai Sinha for moderating today's program wonderfully. Thank you all the EBs and OBs of MahaIP for their full support and joining us. Thank you, Pallavi ma'am, for being always there and solving the technical issues. Last but not the least, all the attendees on Zoom as well as YouTube Live for joining us. Requesting all to please join tomorrow, 1st of March at 9 p.m. for Journal Journey. Thank you so much. Good night.
Thank you. Thank you, everyone. Thank you.
Thank you so much.
Thank you so much.